Opening.
Yeah, I guess I just entering here.
Hi, Ken.
Hi, Maggie.
How are you doing?
Good afternoon to you.
Hi, Ken. Hi, Margaret.
Hi, Lindsay. How are you?
I'm fine. And I'm Total News. Let me assume.
Oh, hi, Toto.
I'm Total. I think we can wait. We can wait for some time so that we can get a quorum. Then we can start our presentations because I can see even most of our presenters have not logged in. So we can just wait for some bit of time. Then when we get a quorum, we can continue. Is that okay?
Yes. Just to check.
Yes,
just
we wanted to.
confirm.
Oh, okay. Go ahead, Maggie. I just wanted to ask the same question.
This session, is HRC going first? Okay, is it for the HRC group?
Okay, so in this session, we have 2 sessions. So HRC is in the second session of the presentation because we have 4 presentations before you.
Yes.
But then now that will depend on the presenter's availability. So let us just wait for the quorum, then we can know from there. But your presentations are supposed to come later.
So yeah, in case they all come, the 4.
Yes, so you have the 4
time
and
are they
framework
for planning. So the
yes.
first block is going to take how long?
Each presentation is going to take 15 minutes.
So that's 1 hour.
Yes, so that's 1 hour, depending on availability of all presenters. So if one is missing, then that means we might take even less time.
Okay, and then between the 2 blocks, is there a discussion? Again, I'm asking so that I can plan myself properly. I have to be also in another place sometime. So after the 1 hour, like just thinking they all pop up, that how much time do they have to discuss? Then we go, then we can come in.
I'm organizing in such a way that we can get the questions at the end of the first session, maybe 2 people, then the rest can give their inputs on the chat.
Yeah, okay.
Yeah, then now we go to the next session because if I leave it open, we will even go up to 6, and given that our time has
I know, yeah, we have. Yeah, let's be strict on time because I know, I mean, we were meant to come in the morning.
Yeah, I understand that. So what I'll do, each person will take 15 minutes.
Yeah.
For the first session, then we have like a 10-minute break.
When it's not around, we go ahead with the next like that.
Yes. So each person will present, will give their presentations. Then afterwards, people can react to the same so that everyone gets the opportunity to present and also share them.
Yeah. Thank you so much. That's very clear.
Thank you. Okay, let's wait for the rest.
Yeah, I think let's just call our team, even though we know we won't be presenting right now.
Okay.
But if we are all here, we can even swap and we go first.
Actually, we are only 2 plus some Total News.
Yeah, it's Ken and myself. For our team, I think just 2 others. Let me just check where they are.
So you're the ones who are going to present on the 5 areas, because I'm seeing it's presentation by APHRC.
Yes.
Oh, so you're the ones who are going to handle the 5 topics.
Yeah. So, okay. No, not just us. We are 5. Like you keep swapping, but it's one long presentation rolling. So,
okay.
Yeah, just have to say 15 minutes each at the most.
So the afternoon sessions have been pushed to tomorrow.
I am not aware of any communication, but I think as soon as they let us know, I think they'll update us accordingly.
Okay.
Yes. I'm also waiting for confirmation for the same because I'm also attending virtually. I'm not on the ground. Good afternoon, everyone. I want to welcome you all to this session. We were still waiting for some of the presenters, but given that we are a quorum, we can just start, and then they may be able to join us later. So this is the session on the Nurturing Care Framework, childcare in diverse religious and cultural settings, protection and safety in childcare. In this session, we were supposed to have 2 sessions. The first one is the one that I've just mentioned. The other session was we are going to have a presentation by the Africa Population and Health Research Center, where they have a couple of presentations, and they are going to be presenting on childcare in urban, informal, and diverse cultural settings. So just before we start, I wanted to find out if I just want to find out if all of us are here. So let me just counter check and see if everyone that is present. Sorry for that. Yeah, so I just wanted to find out if all of us are here. So the first presentation is supposed to be done by Christine Odero or Jane Kuria. Is Christine Odero or Jane Kuria available or present? Okay, so I see that Christine and Jane is not there. Dr. Anil. Dr. Anil is also not present. The other session was supposed to do the presentation, and then the other one is Janet Neto. Is Janet present or available? Well, if Janet is not there, I can go to the next session which was supposed to have. She will be joining us shortly. We have the presentation by APHRC. So I think we can start with the latter session. Maybe Ruth Karibu, maybe we can start with the session by APHRC as we wait for the presenters in the other section to register or log into the details. Ruth? Ruth, can you hear me?
Looks like she can't hear you. Let me just give her a call.
Okay.
She might have.
Go ahead, Maggie.
Hello, sorry, I am on call. There's a whole team that wants to join this team of ours, and
Okay.
they are having trouble. So I thought I had my name. Yeah, so just kindly give me a few minutes, and I think Ken will be will be introducing the speakers from this team. Thank you.
Thank you.
Okay, so Lindsay will start.
Just a minute, Ken.
Okay.
Before we proceed, we are going to have presentations from each and every one of us, especially those who are presenting, and we are going to take 15 minutes each to do the presentations. So after the first section, we will have almost around 10 minutes where you're going to give your comments or your reactions, but you're also free to react or share in the chat box. So after that, then we'll go to the next session where we'll get the other presenters who will have joined us by then. So Ken, kindly do your presentation. Please let us adhere to the time because also of the timing of the program.
Thank you. So I'm Kenneth Okelow from African Population and Health Research Center, and I work as research officer in the ECD project under the Maternal and Child Wellbeing Unit. So what I'll do for this session, I'll just stand in for Ruth, who was supposed to be the chair. I will chair for the presentations, and our presentations will last around 5 presentations. So we'll try to do them in 10 minutes each, and then after which we can have the question and answer session as Bill just said. So we'll start with the first presenter, is Linda. Linda Okelow is a research officer at the Maternal at APHRC, and she has been working in early childhood development projects, and currently she's working with the community in the urban informal settlement, which is focusing on community of practice model and how it is implemented in Korogocho and Viwandani to improve quality of daycare center services. So Linda, you'll go ahead and do the presentation. Do I need to share my screen?
Thank you, Ken. I'm wondering, I'm not able to share the screen on my end, so I don't know how we will be able to project the slides.
Yes, I can share my screen. Let me try if...
Yes, please. Yeah, thanks. I'm ready.
Oh, I can see it has been disabled. So Lindsay can help us in that. I think maybe the Mtoto News host didn't give that right.
Yeah, kindly Mtoto News help us to share Linda Okelow's presentation.
Or they can activate it for us to share. I'm assuming that, like in our scenario, we made a few changes to the slides. So if we could be allowed to share our slides.
So Mtoto News, kindly the one in charge, enable Kenneth to share their screen so that they can share the presentation for this session.
Okay, let's wait. Still, we are not able to. Maybe, or they can share from their end so that we save time.
Yeah, you can start presenting, but you can also share with it. I'm sharing my email so that I can project the same because I can be able to share my screen.
Okay, please share your email so that I can we can send.
Okay.
You can put it in the chat box.
So Ken, you can continue. I've shared my email address. Maybe you can proceed as I receive it and project it for you.
I haven't seen it on the chat. Okay. But I have sent through email.
No, I've sent on the chat.
Can't see it. The last one I see is the one that you said, good evening, good afternoon. So Linda, you can just do a brief okay, I cannot see it. Linda, you can do a brief introduction as we are waiting for the presentation.
Okay, yeah, I think that's okay, Ken. So good evening, ladies and gentlemen. I will be speaking on behalf of the Community of Practice project. So this project basically was aimed at improving the quality of daycare centers in 2 informal urban settlements in Nairobi through a supportive assessment and using the community of practice approach. So we would just want to briefly share the lessons that we learned from the intervention. So I think that is just a brief introduction that I have. The rest are in the slides. So if we could, if we could get that acted on, I think then we can be able to move together.
Yeah, you can continue as I wait for Ken to share with me your presentation.
Okay.
Yes.
So just a brief background. In the informal settlements, we find that there's a high demand for daycare centers because of the increased need for women to participate in paid care work. And at the same time, the supply for these centers is growing because they're coming up unregulated and they come up very sporadically. So we find that there are so many women who are starting up daycare centers in their households or just starting to get an income out of it. And so the challenges that these startups encounter are that they don't have skills, they're not trained. We have poor living conditions in informal settlements, such as poor sanitation, lack of access to clean water, poor hygiene conditions, and such conditions are compromising to the growth and development of children. And therefore, this project was aimed at co-designing and testing the feasibility of a system that would then offer supportive assessment and build the skills of daycare center providers in these 2 informal settlements. So our long-term vision was to improve the quality of paid daycare centers so that children who are in this poor urban setting can have better opportunities at care. So that is basically the overall objective of this study. So in terms of methodology, we adopted a mixed method design. We used both quantitative and qualitative approaches at the pre-intervention stage, as well as at the post-intervention stage. And like I mentioned earlier, the study was conducted in Korogosho and Viwandani, which are 2 informal settlements in Nairobi. And these places are of particular interest to us because APHRC has done remarkable work in these informal settlements. And so it was easier for us to work there. So the study population, we selected 68 daycare centers out of a number that we had mapped earlier. So we did an initial mapping of daycare centers, and then we settled on the 68 based on the selection criteria that we used. And we also worked with the 20 CHVs, community health volunteers from the 2 informal settlements, as well as other stakeholders. So we involved other stakeholders at the pre-intervention using a phased approach where we held a series of workshops and consultative meetings, both on a virtual and face-to-face models due to the COVID situation in the country. So this was to help us to develop to co-design the community of practice model. So eventually we settled on 4 modules that we used to train the CHVs. So we outsourced an organization called Kidogo, which helped us in training the CHVs. So after training, then the CHVs went down as trainers of trainers to train the center providers in smaller groups. So this is how we imparted skills on the center providers using small groups that then we were able to train them on the modules that we had developed. And these modules are, if I can just mention briefly, we had the module of learning through play, child protection, health and WASH, as well as a module on business administration. So in terms of the procedures, we co-designed the intervention at a consultative stage with the different stakeholders from the county, as well as the sub-county, and of course with the project team as well, where we developed the training module. And then we went out there and did the mapping and profiling of daycare centers. And then we selected 68 daycare centers where we worked. We also assessed the knowledge and skills of the CHVs and the parents, after which we went to test the intervention. So that is just basically how the project moved. So currently we are doing inline data collection activities where we are trying to see how the skills and the knowledge of center providers and parents have improved at the end of the project to compare with how they were when we were starting the project. So just to go to the key lessons that we learned during this project, there's a need for daycare centers to be trained and to be given skills, because like I mentioned, these centers are coming up at a very high rate. They're not regulated, and yet the people who are starting them up do not have skills. And as well, the conditions of informal settlements are dire, and they're not as conducive as would be ideal for children's growth and development. So we also realized that there's high level of poverty, there's lack of knowledge, there's lack of skills. So these are areas that need interventions very urgently. During the project, we had a very positive response from the stakeholders that we worked with. The CHVs as the intervening personnel were very enthusiastic and supportive of this project. And we highly recommend that they need to be supported, in the areas where they have weaknesses, because they're willing to be trained to deliver not just this intervention, but other interventions as well. So this intervention was very acceptable to them, and the center providers also accepted this intervention. So these are areas that we can capitalize on to improve this intervention and to scale it up. So like I mentioned, there's no clear regulation of daycare centers in terms of licensing and processing. So this is an area that needs to be highly looked into because ECD policies are not clear from age 0 to 3 years. If you ask them, they say that they're treated as businesses. So there's a need for daycare centers to be regulated in terms of licensing. And we highly recommend that different stakeholders should work together so that such interventions like the community of practice are scaled up for sustainability, and they are useful in the long run. So just to give a conclusion, we need to support daycare centers in the slums. This cannot be overemphasized. And the stakeholders need to work together to support the resource of communities such as the informal settlements like the CHVs, so that they can offer solutions at the basic level where they work. We expect that from this project we will get more evidence when all the data that we have collected is analyzed and disseminated and shared with different stakeholders. And so we anticipate to have workshops with the various stakeholders in the near future to further refine this intervention and to look at modalities for scaling it up. So as I finish, I would want to acknowledge the study participants. We would also want to acknowledge the support that we got from the national government, the NMS and the sub-county teams from Raraka and Makadara, our funders, the British Academy, and the Kidogo team for giving support in training, as well as the investigation team at APHRC and the University of York. I thank you all for listening. Back to you, Ken.
Thanks, Linda. Apologies that the presentation didn't. We were not able to send it in time, and then we were not able to project it in good time. But thanks so much for doing the presentation, and I hope those who are having questions are keeping them, and you will share at the end of the presentation. I think Lindsay is mentioning that she's also not able to share her screen too. So we are requesting if Total News could also give us that right so that we can share, we can project our screen, or if they have the presentations, they could do the same. And I'm also seeing, as Ruth has mentioned in the chat, that it seems like there's another presentation going on in the room. And it seems that there's a presentation in the midway. So we can hear from Total News on the way forward. Are we listening to the presentation online or the one that is being done on the other side? Maybe Lindsay, you can guide.
Yeah, thanks. I think Total News can guide on the same since they're the ones on the ground. Maybe we can hear from Total News before we proceed.
Okay, so Total News, please assist us on that. Or does it mean that the virtual participants are listening to one, since we had 2 programs going on?
Yeah, I think it seems the same. Let me just quickly find out, then I can get back to you.
Okay, thanks. So maybe we can give 2 minutes for that before we go to the next presenter at from pictures. So I think not to waste time, we could just proceed with the presentation as that confirmation is going on. I'm getting to know that the presentation going on at the conference room where we're being shown might not be for our group, so we can still go on. So the next presenter, I'm introducing the next presenter, who is Dr. Patricia. I don't know if she's here. Yes, she's here. So Dr. Patricia Kula is an associate research scientist at African Population. Yes?
Sorry, Ken. My concern is that the group, other than Regina and Lindsay, we are all APHRC people. So we are basically presenting to us. I don't know if you heard me.
Yes, Ruth, you are breaking, but we have heard you. And I think maybe we can get a clarification from Lindsay if there are others who, since he was confirming from the people at the ground, if there are others that are joining from just University. I'll hand over to her.
I see Lindsay has confirmed that we are 2 groups. So
Okay.
Lindsay, are you in a room where there are other participants?
Lindsay is also joining virtually. We had a conversation with her earlier.
Oh, okay. Because then that means Lindsay was supposed to, okay.
And Silas, Patricia is not presenting. Silas is presenting, and he has also joined virtually, but he's also in the room.
Yeah, yeah. Well, I've spoken to Silas and Regina. They're together. I don't know how many people are there, Silas, where you are.
Sorry about that.
Yeah.
It seems there's a problem with the.
But we are with Mtoto here. Mtoto News is here with
Going
us.
on in the same breakout room
Yes,
that we
please
are,
let them
that
clarify
we
for
can
us.
proceed as planned as they sort out the issue. So Ken, I think we can continue with the next presentation as they sort out the issue from the other side.
Okay, thank you so much, Lizzie. The next presenter is Silas Onyango.
Ken,
So Silas, before you start presenting, are you able to hear me?
Yes,
Hello?
yes, we can hear you,
Ken.
Ken.
So the next, I was saying that the next presenter is Silas, but Silas is at Just. So Silas, you can give us maybe an update before we.
Ken, can you hear me?
introduce you. Yes, we can hear you, but you are breaking.
So maybe if Ken cannot hear me, we can proceed with the next presentation that is under APHRC. We've just had the first presentation on on quality of childcare in urban setup, the informal settlements in Nairobi. So maybe the second presenter can proceed with the same presentation as we sort out the issue from the other end. Thank you. Ken?
Thanks. Are you able to hear me now?
Ken, I
Hello?
can hear you.
Yes.
I can hear you. And so with the Mtoto News here. So they were saying that we were using a wrong link because we are using link for breakout room 3, but we are not in any
but you are
breakout
on
room.
mute.
So
We
which room are we supposed to be?
we cannot get you. Silas?
I am not on mute. Ken, can you hear me?
Yes, we can.
Yeah, we can hear you, Silas.
We can hear. I think there's
Yeah,
a
so what
problem with Lindsay's network.
Yeah,
So
because
go ahead.
what's happening is that
So
is that
someone hear me?
we have been told that we are using a wrong link. The link that using is the same one that breakout room 3 is using. So
That's
which
what we use.
I don't know whether we can. They are here with us. Sitting outside actually a room.
Or can anyone hear me? Margaret?
Can they share with us? Can they share with us that link?
Oh my gosh.
So Silas, can they share with us that link so that we proceed?
I think we seem to have a problem.
I think there's a problem. Silas, even before you share the link, do we have people on that other link that is being said we are supposed to be on? The virtual link.
So you see what? You see the breakout room 3, they're only showing what is happening, but we cannot hear the presenters. So I don't know whether we could just continue with this link.
Hello, ladies and gentlemen. Why don't we just proceed? Because we have 12 participants here, and I think the link is, though not very good, but we are managing. So instead of waiting to resolve the issues, because there's a recording happening, so we can again share with other people what was discussed on this, so that we work on time and make sure that we are able to have meaningful engagement.
Okay.
Can anyone hear me?
That is better. We can just proceed with the presentation. Yes, Maggie. Or is that speaking? I think as Lindsay says,
I just wanted to say.
You can proceed. Okay. Yes, go ahead, Ruth.
I was requesting that they disable the video of the one that's going on. It's a bit distracting for me at least, if it's possible,
Just that we have
since
not, we have
there's
not
no
been able to
connection
get,
with.
we have not been able to get a direct communication from.
Silas is with Mutoto News.
Okay,
No,
so can we proceed?
very hostile.
So it is possible to proceed.
But I can't share the screen also. I'm being told host participants screen sharing.
That is another thing that's another challenge that we encountered in the first presentation. None of us is able to share the screen, either me, Lindsay, or any other participant. So if Total News could help us in enabling that,
because of
which
the,
we had asked
the presentations. So if they
Hello, sorry,
so
sorry.
hello,
Ken, sorry, I was trying to talk, but it seems that I was muted or there's a connection.
Now we can hear you, Lindsay.
Yes, sorry. So I've talked to the people on the ground, but it seems there's a clash because someone is presenting currently. So we are advised just to continue then as they sort out the issue. So I think Ken, you can proceed with the presentation.
So Lindsay, the challenge is we are not able to present. The Total News did not enable us to share our screen. So if they can enable us to share our screen, it can be possible for us to go ahead with the presentation. Or we'll just be talking through our.
Ken, I will suggest that we go on as someone has mentioned, because I think there's also hostility here with these people. So I think we just continue without sharing the screen and we finish this presentation. Yeah. Because
yes, kindly let us just continue as they sort out the issue.
Okay, thank you. So the next presenter will be Silas Wanyango. Silas Wanyango is a research officer at African Population Health Research Center in the Maternal Child Wellbeing Unit. And he's going to share a presentation on exploring the childcare market in Mukuru slums, the Nairobi Early Child Care and the Nairobi Early Child Care in Slums study. That is a NESC study. So Silas, please go ahead.
Thank you, Ken. I hope you can hear me. I'm here with Regina, who is taking notes, and we have the opportunity to make this presentation. I think this is an ongoing project that is happening currently in Nairobi area, Mukuru area, Nairobi, specifically the Mukuru that lies in Starehe, the Mukuru lies the main question that we're asking who is looking at the young children. It's about connection because the gist connection is also not very good. So then we also have this. I will also present on the aims. I'll present a bit on the study site that I've also highlighted a bit, and then tell you about the designs so far, the results that we have. But like I said, this is an ongoing study, so we need to also some of the outcome in informal settlement has unique adversities, especially to the children. But then there is emerging use of paid daycares, and some of them have poor low quality. But so there is limited evidence of how and where this know that this particular somebody who wants.
Yes, Silas, I think I don't know if you need to maybe connect to different network, because all of us are not able to hear. We just had the introduction, and then after that, now you started breaking. So is there an option of another network, or someone else can within our team can volunteer to continue with the presentation?
Yeah. I think we can't hear Silas clearly. If somebody from his team could pick up and maybe just follow up and continue the presentation.
Okay, thank you so much. So we can, who can volunteer to do that in our team? And then the person who has just spoken now.
Do that.
The person who has just spoken now, kindly maybe you joined with the link that was shared by Lindsay. Kindly just rename yourself so that people are able to know who is in the team.
Oh, sorry. My name is Raphael Sungu. I'm country director for Build Africa.
Okay, maybe kindly just rename that.
For reactions, yes.
So Ruth, go ahead.
I mean, Lindsay's team.
Okay. I can pick up on the next presentation.
So let me give a background just to because he comes in. So Ruth works at African Population and Health Research Center as a research officer, and her research has been focused on ECD, and she has been looking at quality of daycare centers, as well as
the interest of meeting OVCs in our communities. Let us now carry the OVC package to the prison too.
Total News.
And then as you package it, so that we are not left behind the way we have left behind some learners, and nowadays.
So I think, Ken, you can proceed.
Okay. So I was saying that I am introducing Ruth, and I've mentioned her work, which has been around early childhood, daycare centers, as well as
reaction to the presentation. Do you have?
Some Total News need to mute.
Yeah.
Ken, I think you need to hold on. There's quite some interruption. And Ruth's presentation stands to be interrupted. Maybe we should get some guidance from Total News or something.
The challenge is that getting guidance has been, that is what we started with. It's almost 40 minutes since we started contacting them, but we are not. So if you could just go ahead, and in the event that they interrupt us, we pause for a while and then move on. So Ruth, go ahead.
Well, what you have just shared with us, which is a bit, it's emotional and it's really, you feel, you get scared. I'm just wondering, have you done the same sensitization to other prisons, like supposing
I can see Regina has raised her hand.
And I tell them
Regina,
I work with this project and I want to come in and bring something for the children.
Hi, Regina.
How will I be received? I'm just building on what he was saying. Thank you.
Regina, please go on. We're waiting on you because you might have a solution since you're on the site.
There's I've just given an opportunity.
I'm thinking because we can hear Total News, it's likely that they can also hear us. Total News, can you hear us?
Faraja works in almost all prisons in the country, and recently we launched even a project on beds. And currently all women in women prisons are sleeping on, every woman is sleeping on a bed, and even their children. So our mandate is all over the country, but sometimes it's overwhelming. The matters to do with children are quite overwhelming because the safety aspect is involved, even the reintegration, and it needs a lot of collaborative approach.
This is very tricky
because
a lot of people coming in together and working together to see
how best we can approach matters to do with children all over the country.
Are you in touch with anyone in Mototo?
Yes, I can call Jennifer, but she's the lead. She might be so overwhelmed.
Try to call her and let her know what.
We've looked for guidance since morning, since the conference began, but Yeah, let me try.
Okay.
Yeah,
I
just
think
tell
it's
her
worth
there is
trying.
Okay.
there's a crash.
We are not likely to make headway with things like this anyway.
Yeah.
And
Yeah,
even presenting here without.
I think the only solution we need here is Mutoto to log off, because they seem to be in a room and there's no one else virtually. I mean, you're all here. So if we are all here, the virtual people, then we just have to make a decision to allow the people physically in the room to stay there and ask virtually to use the platform.
Now that they have muted, we can just go ahead.
Yes, okay. Actually, I'm talking to Rachel. She's on the ground. She's sending me contacts of some the person who's in the room so that now we can coordinate. But I think now that
let them even take off even the video, because it's not fair. As in, we are listening to something different and we are seeing something different. So
and let them also give us a right to share our presentation, because
let them take off the video as well.
It is really hard for the
if they log off, they need to make someone else host. Otherwise, they'll shut down the meeting.
Okay, they may not log off. Let them mute and let them take the video. We can coexist.
Sure. So we can continue. Let me talk to them to mute themselves. Then we can continue because the sessions are being recorded.
Okay. So Ruth, go ahead with the presentation. Then maybe if Ruth is still working on resolving this, you can bring another presenter. So I'll
continue with the session. That way we won't waste a lot of time moving into that room that you're saying that's empty. Because now if we all log off, that it will save us time. The challenge is that we can hear what is happening in this other room. So it's very distracting. We can't talk amongst ourselves. Yeah, so if it's possible, just log off the Total News that's logged on onto that room we are in with Lindsay. She will join when during this session. I think that's easier, as opposed to all of us migrating because it will be so difficult. Okay.
Okay, Lindsay has raised her hands.
Ken, are you saying something?
Yes, I'm saying Lindsay has raised her hand, so I wanted to give her a chance to say something. She has something to communicate. Hi, Lindsay. Okay, Ruth, go ahead. You are mentioning something.
Yeah, so what I'll do, I've requested that they log off the physical room because they're saying we have another room, but I feel that will be wastage of time us moving because the room was created late anyway. So what we can do, I think what is necessary right now is to log off the team that we are seeing physically, because no one is actually listening to us. They're listening to the presentation that's going on. So that will save us time as opposed to us moving to that new link that was created. So what I'll do, I'll just start presenting and hopefully there'll be no interruption. Hopefully they're migrating to the other room now.
Yes, I can see now you're the host. Yes, now you are the host.
Okay, yeah, so they have moved us.
You're even able to share your slides.
To share the screen.
Better. Yep.
Yeah,
you can even take off their video. Oh, yeah.
Okay. I don't know if you can still see the video.
We do, but it's okay.
I don't want to waste so much time removing it, so please allow me to go on. Oh no. Okay. Someone please guide me on how to remove that video.
Just go on.
It's less bothersome. Just go on, because now we're sharing the slides. We are more captivated by your slides more than the video on the side.
All right. So I will, the presentation that Silas had begun presenting is titled "Who is Looking After Young Children in Slums?" And the we're looking at findings that have come out of a mapping exercise out of the project by the title Nairobi Early Childcare in Slums. So the presentation overview will look at the aims and objectives of the study, where the study is being conducted, the design, and finally the results and the impact. So just
do you want to use slideshow?
Okay.
Yes, fine.
Okay, so, all right. So in the urban informal settlements of Nairobi, there's a heavy burden, or there's a burden on early childhood. And this is because of disintegrated families, in the sense that families no longer live like in the rural areas where we have multiple caregivers who can look over children. We also have increased entry into the workplace for possibly, if we have two caregivers in the family, or we have a father and a mother, they possibly both are working or are doing work. Then also women have gotten into paid work, and so are not primarily taking care of children. And then there's also the fact that these families may not be able to afford paid care to nannies or house help. So it becomes very difficult for them to have such kind of opportunities. So as a result of that need, or that reality, then there's the emergence of paid childcare that are usually called daycare centers. Now, these daycare centers are deemed to be of poor quality because there's really no regulations or minimum standards that guide on how they are run within the urban informal settlements. So anyone could wake up and decide, I would like to run a daycare center. And because the demand is there, then the daycares keep emerging, or the supply keeps becoming more. And the lack of regulation then results in the poor quality. So there's been very little evidence around these daycare centers. And so this study sought to carry out sought to look at three things. The first thing was to understand the use of paid childcare. The second thing is to understand or to document the provision of paid childcare in Mukuru, which is the study site, and to assess its quality in an objective manner. Then finally, we wanted to gain understanding of both parents and carers regarding the behavior around childcare in Mukuru slum. So as mentioned, the study site is in Mukuru in Nairobi, and Silas had talked a little bit about which areas of Mukuru, or which radius of Mukuru was being covered. So the reason why we settled for Mukuru is that Mukuru is an industrial circuit. It's surrounded by industries. And so there is a lot of demand for low-income workers. And so parents need an alternative where they can leave their children. It's also one of the longer established informal settlements in Nairobi, and the existing contacts with the current project. So the current population is as projected there at 300,000 across 6 informal settlements in Mukuru. So the study design, there are 5 areas that the study seeks to explore or has already started doing. There are household surveys, qualitative research with parents and carers, where we want to understand the issues I've talked about, the decisions that guide parents and carers to provide the care or even to choose the care. But the one that we are interested in for this specific study is the mapping exercise, or the findings that we're providing today is what came out of a mapping exercise. So the others are assessment, the quality assessment, and then also with the daycare providers. So what we found when we went out to look at what is available, what is there in Mukuru in terms of these daycare facilities, we looked at some issues or some broad areas that allowed us to come up with the findings. So the first one was location of childcare facilities. The second one was the type of facility. Then we also looked at the training level of the people who are providing this care. So in terms of the location, you see the distribution in location. We have Kwanjenga and Kware, as well as Kwaruben, having a huge or the huge proportion of daycare centers. Then we have Landmawe, which has a few, and Nairobi South also has a few compared to the 3 areas that really have a huge chunk of the daycare facilities. Then in terms of the type of facility, we find that private carries about 64%. What we mean by private is that these are individuals or entrepreneurs who have come up and decided to run a daycare facility. So it could be someone who wakes up one day and decides to translate their house or their home or rent a room and run a daycare center. So when we look at the training level, it's interesting to note that the ones that the majority of the respondents or the sample that we looked at have an ECD certificate. They found reason to go ahead and do ECD. Some have some proficiency, and also a significant majority do not have any training at all to run these daycare centers. So if you look at my extreme right, you see that majority are operated for 6 days or the entire week. And so that speaks to the demand of these daycare facilities. So what is the impact of the study? The impact of this study is that we are able to understand the current situation and offer in-depth information about the existing situation about daycares, which is able to inform people who would like to carry out intervention programs based on research, or even to develop new ones that would be able to meet the needs of the carers as well as the providers in these areas. Also, we anticipate that childcare will offer a good platform by speaking to the quality or even alluding to what quality should exist. Then it offers an opportunity for the most vulnerable children to get some form of care at a time that is most important to them, and that is the early years. So I'd like to also acknowledge the study team that was involved or is still involved in carrying out this study. We have the principal investigator, the co-principal investigators, and then we also have co-investigators, and the team constitutes of individuals from the London School of Hygiene and Tropical Medicine, African Population and Health Research Center, the University College of London, and Newcastle University. Thank you very much.
Thanks, Ruth. Thanks so much for that presentation. We'll go to the next presenter, who is Elizabeth Mwaniki. I'll introduce Elizabeth Mwaniki. Elizabeth Mwaniki will take us through community perception and practices of early childhood development. So maybe you can move to that presentation. In urban settings in Nairobi. So Elizabeth Mwaniki is a research officer at African Population and Health Research Center with interest in health and wellness of families. She has worked in several research projects that are focusing around access to maternal services, community management of malnutrition, and caregiving practices in ECD. So please kindly go ahead.
Thank you, Ken. Welcome, ladies and gentlemen. I take you through this presentation that sought to understand the perceptions, the knowledge and attitudes of early childhood development in an urban poor setting in Nairobi. Thank you, Ruth. You can continue moving the slides. Yep, that is it. Keep going. There we are. Now, this study was important to us based on this background, that caregivers in low-income settings face unique challenges, challenges associated with poverty, such as the low education levels, low income levels, and quite often food insecurity, is widely prevalent. We have also found that caregivers in these settlements are largely, over 50% young mothers or adolescents, and with children between 0 and 5 years. And that also, presents another angle besides the low knowledge or low education levels. We also see poor parenting behaviors, related to this low knowledge, then maybe you can still go back. And all of these factors, including environmental challenges, infrastructure challenges, have a significant role in just making way or laying a foundation, or even facilitating, enabling childcare practices in this environment. You can move on. And so our objectives were twofold. One was to understand the ECD knowledge, attitudes, and practices in this urban poor setting in Nairobi, and to explore the contextual factors that drive community perceptions and practices of early child development. You can move on. You can move to the next slide. Our study design was cross-sectional. It was a qualitative study. It was conducted in 5 villages of Korogosho ward. Korogosho is a low-income settlement within Ruaraka sub-county, Nairobi. We sampled 139 participants, of whom some were mothers or primary caregivers, with children aged 6 months to 3 years. We spoke to county and sub-county health managers and community health volunteers. Now, these participants were, involved by way of focus group discussions for the mothers and primary caregivers, because we felt in this form, then they were able to share knowledge, and be able to, just present the situations as per their practices and understanding. We also sought to do KIIs with the county and sub-county health managers. Community health volunteers were involved by way of focus group discussions. I summarize this information in this table in the next slide. Kindly move the slides. Right, yeah. And our focus group discussions are going to mention, even though we had a total of, 64 participants, we held them with 8 to 12 participants in each focus group discussion. So what you're seeing there is a collective number of the number of people who participated. Now, following the interviews, and I need to say that these interviews were recorded and later translated and transcribed. We, the study team, reviewed these transcripts and were able to analyze the information coming out thematically. Later, we also involved a coder to, just put the information in a coded form. And our results are, as this slide is already prompting, we can move it to the results slide. We summarized the information in 4 major themes. We also looked at the community perceptions of childcare, of children's needs by the caregivers. We also looked at the community practices in providing nurturing care and stimulation. And finally, we also looked at the barriers to meeting children's needs. You can move along. So I begin with the community perceptions of children's needs. It was interesting for us to just realize that for this community, wholesome provision of basic needs to the child was equal to providing to all of the child's needs. Caregivers spoke about nutrition, clean environment, and parental love in these headings as are provided here. Now, many caregivers and CHVs as well were very clear about the need for a child to be exclusively breastfed within the first 6 months of life, the need to transition the child to a balanced diet after 6 months, and concerning clean environments, how a hygienic environment is a safe environment and protective of the health of a child, and then finally, there was the aspect of parental love, where we saw both caregivers and CHVs acknowledge or recognize that a child needs consistent parental love from both the mother and the father. However, the CHVs helped us see that it was not always that female caregivers, or mothers for that matter, are able to provide this kind of, love or close engagement with their children, largely due to, the care demands that this caregiver has over this child. You can move to the next slide. In this one, we look at the knowledge and perceptions of early child development, and like the previous slide has already preempted. What was summed up as good early child development care was really that wholesome provision by way of nutrition, by way of healthcare, by way of a good environment and parental love. It is clear for us that there's low understanding amongst caregivers of the need to actively stimulate their children's development. The whole concept of developmental delay was not strongly appreciated by caregivers. Some felt that children really grow at different rates and that they should let be. You cannot compare how one child is developing to another because they're all subject to different things. But a few also felt that, where a caregiver feels that that the milestones are not being achieved as should be the case, then there is need to seek, medical attention. We also found that CHVs recognized that early childhood is an important period for intellectual development and long-term well-being of children, far more than the caregivers did. I mean, they had a sense of it's important to understand how each child is transitioning through the phases, interact closely with the child to understand where they are not presenting as expected, and be able to bring that to attention of medical personnel. You can move on. Concerning the practices in providing nurturing care and stimulation, we summarize this in two ways. We saw that parent-child interaction and play was recognized by both caregivers and CHVs. Even caregivers, feel that it's a good thing for a child to play. Some caregivers would express this as when a child is playing, that child is not sick, and so in a sense, we're able to appreciate a playing child to some level of wellness, all right? However, they expressed limitations in their ability to play with a child. Those limitations included the structure of where they live, just their domestic space, and the lack of sufficient space for their children to, play as would be ideal. Even their outdoor spaces are limited because of, the structure of them, and the safety of the environment. Caregivers were also not readily available to participate in play. Between a caregiver earning a livelihood, coming back home to take on another shift around domestic chores and caring for the child, this caregiver is tired, and not in a mentally prepared place to play with a child. So a lot of the time, children, were reported to be playing on their own, using locally improvised materials, sometimes secondhand play materials obtained from the markets or the secondhand retail outlets. It was also brought to our attention by CHVs that it was normal to hear caregivers scolding children, not because this is how they prefer to have it, but just the stress of caregiving playing itself out when a child is not deemed to be doing the right thing. And that links me to the second part of practices, and that is discipline. Caregivers, some caregivers some caregivers were reported to still use traditional methods of disciplining, and that is inflicting pain by either using a cane or by either using their hands. Many caregivers felt that when a child does something wrong, they need to recognize that they've made a mistake, and this form of discipline is most common and possibly effective. They also did mention or did present, the understanding that even though caning is effective, it needs to be regulated for younger children, and that cannot be done the way a child in school would be caned. And some parents talked about denying the child the breast as being an effective way of correcting or disciplining the child. And so concerning practices, these two were the most emergent of them. I request that we move to the barriers to meeting children's needs. I think right at the top of this list was, just the pressure and the limitations of poverty in this environment, as we've already, spoken about earlier. And there's the lack of accurate information, particularly amongst younger mothers. A lot of assumptions around caregiving, the kind of information like if I breastfeed, my breasts will sag, and so also limited information about development of a child in the areas that cannot be visually seen, cognitive development, emotional development, and we also found that there are cultural and religious beliefs and practices that get in the way of good caregiving to young children. We had that there are cultures that don't allow children to be medicated when they are well. There are cultures when a child's speech is delayed, then they are denied certain foods because apparently that, causes further delayed. And there's a whole aspect of gendered roles in parenting. A lot of the time, we found that, the female caregiver holds a greater burden around caregiving. She very well could be the one, holding a day job and then coming back in the evening, to tend to both the domestic chores and the child chores. And that can be very stretching, as caregiving is already ideally a full-time role for a child who is under 3 years. We also found that family conflicts, things that emerge from alcoholism, use of how money should be used in a household, the issue of single parenthood, the lack of the father's involvement, all time to not presenting or limiting how a female caregiver would find herself in an ideal state to give to her child's needs, because she's a lot of the time stressed and not in a mental state to engage with a child optimally. We found that there's also limited focus on child development. At the health facilities, these caregivers are accustomed to the measures of height and weight, and not so much investigations around, the developmental stages or psychomotor stages of this child. CHVs also, had a voice to this and said that even when they're assessing children in the, in this setting, they will have a MWAC team, which goes to, assess a child for malnutrition. They may have a scale, but oftentimes they have nothing to gauge a child's development in all these other domains with. So they are also left to, just comparing what they think this child should, where they think this child should be at against what they have seen in another child. And therefore also felt that they're not capacitated to take care of other needs, other developmental needs of children in the community. I'll wind up this presentation by concluding this way. But the community is aware of, even though limited, of the importance of ECD, but has very little appreciation of stimulation for development and monitoring the child's milestones. We also find that there is need for more ECD education amongst caregivers and CHVs, that there needs to be the kind of education that allows them to see their children as in a transitional phase during these 3 years, with their capacities and their developments rapidly changing and needing to be assisted through appropriate stimulation. For CHVs, it's also with regards to how they would employ this in their day-to-day work of health promotion. And then finally, we found that there's need for interventions for improving attitudes and practices. And these interventions should also aim to address barriers that we have spoken about: ignorance, misconceptions, religious and cultural beliefs, and other practices that we found present in this community. I'd like to thank the study team, the Saving Brains Grant Challenges coordinator, who are the funders to this work, and the study participants from this Korogosho settlement. Thank you very much.
Thank you, Liz, for that wonderful presentation. We'll go to the next presenter. And I also encourage the participants, please, if you have a question, put it on the chat box. We'll give a session for question and answer, which will be led by Lindsay. So the next presenter is Dr. Margaret Nampita, who is Associate Research Scientist at African Population and Health Research Center. She is particularly interested in the impact of childhood infection and adverse social environment on children's cognitive development, as well as the intervention that improve children's developmental outcome. So, Dr. Margaret, the floor is yours. Dr. Margaret, it seems you are muted.
Oh, sorry. Thank you very much for the introduction. I quickly will present to you another project that we have done within our ACD team, and that is exploring the use of mobile phone technology for optimizing, tracking, as well as responding to children's developmental progress in Korogocho, one of the low-income settings or informal settlements within Nairobi in Kenya. Next slide, please. By the way, can you hear me? Am I audible?
Yes, you are.
Maggie, I can hear you.
Yeah. Please, let's move to the next slide. Thank you. Yes, just a very quick background. A lot of this has been said in all the other presentations. We know that it's like 250 million children, that's about 43% globally, are at risk for not achieving their developmental potential because of many reasons, but particularly poverty, the extreme poverty that they grow in, malnutrition, and unstimulating environments. So the third point is what we really focus on for this study. And we realize that parents need to be supported to be able to monitor their children's development. And this has been presented in this presentation, and to be able to provide stimulation that would enable them prevent or identify delays as soon as possible. And we know that currently there is a lot of use of technology in health and in other sectors to improve service delivery to the grassroots, and including in the low-income settings. There are phones everywhere. Everything is now on the smartphone. So next slide. We thought that this could be leveraged to even ECD delivery of services, but as well as reaching to the households to improve caregiving in the low-income settings. So our main objective was to develop and test the feasibility of using mobile phone technology to optimize, to track, as well as to respond to children's developmental progress in these low-income settings. And what we did, the study, basically, this was a mixed methods, both qualitative and quantitative study, with a course experimental design where we had two arms, the intervention arm and the control arm included a total of 227 participants, who were 119 in the control arm who were receiving the standard of care, and 108 caregiver children died in the intervention arm who who we followed up. We recruited and followed up for 12 months. And at the end of that intervention period, we had an end line where we assessed the main outcomes. These were caregiver knowledge and practices, caregiver stress, parenting stress levels, and ECD outcomes, which were measured using the PCMIT protocol for child monitoring, the infant toddler version. The main domains, the key domains that we looked at for the PCMIT were the fine motor, gross motor, language, social emotional development, and cognitive functioning. And like we said, this was a study conducted in Korogocho within 5 wards of Korogocho that were randomized to receiving either the intervention or the control intervention with a buffer village in the middle. So we divided Korogocho, it's kind of sausage shaped. So one end of Korogocho, we allocated the intervention, and the other end was allocated the control arm with a buffer village or a zone of no allocation in between to minimize contamination. And just to talk a little bit more about the intervention, this was for the parents and their children that were allocated in the intervention. The parents received monthly text messages on their phones. These were not smartphones, the small ordinary phones or smartphone if it was, asking them about the child's milestone, that particular child that was recruited in the study. So we, every month, 5 questions came to the mom's phone or the father, if it was the father in that case, asking about the milestone that the child is supposed to have achieved at that point. If the child was, for example, 9 months, we're asking about the child standing. Are they able to grip stuff? That's the fine motor. They like language. So in each of the 5 domains, there was a question coming to the mom, and based on what the child was doing at that time, should respond back either a yes or no. And if it was a no, then a stimulation message would be sent back to her to do that. If it's language, to encouraging her to speak, the child to talk more, speak more with the kid. And then if it was a yes, then of course she would be encouraged to continue doing what she was doing with the child, you know, that stimulate their development. And for those who said no to a particular question in a domain, the same question popped 3 times. And along the system, the CHV was also connected so that they would also be able to pick up that child that was delayed. I mean, having a no for over 3 months means that the child is not achieving that milestone, therefore they might be delayed in that domain. So the CHV who went there monthly to the household to check on the child was able to also pick up on that, but also our team, we reviewed the outputs for the text messaging for the responses, and we followed up on those that responded no, 3 consecutive no's to a particular question to verify whether the child was actually, you know, delayed, or it was like a mistake or an error in, you know, judging or responding to the question. So we did that for 12 months, like I said, and then at the end, we compared the 2 groups on the outcomes, the parent caregiving knowledge and practices, the stress levels, as well as the ECD outcomes. Next slide. So what you see here in the slide is just a summary of the outcomes at baseline, midline, and endline. We did baseline, of course, as reference and comparing the 2 groups, and also to check whether at the starting point, the 2 groups were similar in terms of the key outcomes. And what we see is there are no significant differences. So that was encouraging. They all started off almost at the same level. And then midline, what we see are some increments or some improvements in the outcomes across the 2 groups, but still we don't see significant differences between the intervention group, those who received the text messages, and those who did not. So at that point, at 6 months down the road, we don't see significant effects of the intervention. And then at end line, that is 12 months down the road, we see significant differences in the ECD caregiving practices, where the intervention group, sorry, I don't have a pointer, I'm not the one presenting, but you see that under ECD practices, the intervention group, which is pink, they score on average 4.27 points, as compared to the children and the parents in the control arm, where the score is 3.63. That's a significant difference. And when we did a statistical test, it was actually significant with a p-value of 0.03. That's very significant. And as well as in the PMCT, that is the protocol for child monitoring, this is an overall score. We still see a significant improvement or difference between the control and intervention, where the intervention is scoring 94.45% compared to the 90.96. So there again, we see a significant effect of intervention, a benefit of intervention over the group that didn't receive. Next slide, please. Can we move to the next one? Yes. So yeah, what I was presented before were unadjusted effects, or just crude means comparing between the two groups. So what we see here on this slide are effects of the intervention on the caregiver's knowledge and practices, as well as the PSI, the Parental Stress Index. So like I said, even here we adjusted for baseline scores, even though we didn't have significant differences at baseline. Ideally, you have to adjust for them. So we did, and we still see a significant effect of the intervention on parenting caregiving practices. In the first or in the second row, just go with intervention arm, where you see 0.40, that is the effect size. Yes, and it is statistically significant. The control arm was used as the comparison or the reference arm, so that's why you don't see statistics in there. And for these outcomes, parental outcomes, knowledge, practice, and PSI or Parental Stress Index, we only saw significant, differences in parenting practices, with the intervention doing, of course, better than the control, meaning the intervention actually improved parenting practices over the 12-month period. Can we go to the next slide? Yes, this slide shows us adjusted effects of the intervention on the ECD outcomes, the PSI, scores. What we see again is, at end line, we meant to use the PSI as it were at baseline and midline. However, there was an interruption by COVID where we couldn't do face-to-face assessments. The PCMIT has an aspect which requires face-to-face. So we couldn't do that because of COVID. That was at the peak of COVID last year in July. So for that, we actually inserted the ASQ3, the ages and stages tool, to assess that. So we combined PCMIT as well as the ASQ, and we actually found significant effects of the intervention on the PCMIT and ASQ. But we also, of course, had to adjust for age, and we see significant effects of the age on the ECD outcomes. What you can say on both slides, both the parental caregiving practices, which were significant, and the ECD outcomes were also significant. However, we see trivial or small effect, 0.4 for PCMIT, and what was it before? I don't remember. For their caregiving practices. Those are small effect sizes, but even though they are small, they are indicators that the intervention really has a potential to improve outcomes. We are thinking if we actually extended the intervention to beyond 1 year, maybe 2 years, and if we had a bigger sample size, probably we would see bigger differences in these two outcomes. Next slide. Yeah, we also looked at the feasibility and acceptability of the intervention among the caregivers that received it, as well as the CHVs. But this slide is basically showing us how the trends of how the CHVs really kept on the intervention. So we started with 108 caregivers in the intervention. That was in July 2019. And of these, 102 caregivers responded, which was 94%. That was really high, response rate. And as we went down, we actually had a high response rate until towards the end in April, where it went down 76%, 75%. That was still around COVID, but generally having a response rate over the 12 months of 75 and above was an indicator that the intervention was well received, was acceptable, and also feasible to undertake within this community. Next slide, please. Yes, and we also, of course, like I said, it was a mixed method approach, where we had also qualitative interviews with the caregivers, with the caregivers, the CHVs who are supporting the intervention, as well as other community members that were supporting CHV, for example, the health facility workers and the CHARs. So from these interviews, sorry, this is different from the updated, but yeah, from the interviews, we found that especially the caregivers were giving past lived stories of how the intervention provided them with knowledge and skills of caregiving. You remember from Liz's presentation where they appreciated that children grow, but they didn't actually know that you need to do something for the child to develop better, to develop up to their potential. So they testify that the intervention provided ECD knowledge and skills, and it enabled them to track or monitor their children's development in real time, and as well as provided stimulation tips for their children, which they didn't know. They also said it was simple and easy, that the intervention is simple and easy and convenient for them to use, as in anytime they receive the message, and then often they would have the child there, and then they do what, sorry, could you go back a bit? Previous slide, please. Yes, so they had all these positive testimonies about the intervention being low cost and being accessible anywhere, anytime, and providing better monitoring options, and they didn't have anything actually before. As you see in one of these quotes from the female caregiver, the intervention has been good, and we have been taught how to care for our children, how to listen to the child. For example, when a child wants to play with you, you need to give them time. You don't scold them, etc., etc. So they really had, in line with what we found quantitatively, they had positive testimonies. But there were also challenges with the intervention, because when we were getting in, we assumed that there is mobile technology used everywhere. Everyone should have a mobile phone, but that wasn't the case. We found, like you saw, we actually had to leave out about 25 participants from the intervention who didn't have phones. They didn't have personal phones. So that's a reality. Some people do not have phones yet. So, and then for some of those who had phones, when they lost their SIM card, the platform was designed in a way that it didn't replace. It only work with one SIM card. So unless you change to the same SIM card, then you'd continue on a program. But if your phone was stolen and you can't replace your SIM card because maybe you've exhausted a number of times replaced, then you didn't get back one. So those are practical challenges with the platform. Yes, next slide, please. Yeah, in conclusion, our experiences quantitatively and qualitatively with the mobile phone technology are that a mobile phone-based monitoring of child development in the low income settings is possible, it's feasible, it's practical, it can be done, and it has a potential based on those the outcomes in the ECD as well as in parenting practices. It has a potential to improve caregiving practices as well as ECD outcomes. However, we think the small effect sizes could probably because of the relatively short intervention period of 1 year, and also not so big sample size. So overall, we think that this is an intervention that has a possibility to be scaled up to a wider population and would have benefit. So with that, next slide. Yeah, thank you everyone. We thank our study participants, of course. Sorry, they're not here. The Saving Brains who funded this project through the Grand Challenges Canada, and the VAL partners who designed the platform, because we worked with them closely to design the mobile platform, and also the Ministry of Health, especially the chairs, and of course, with the higher level, personnel at the NMS and sub-county level for their support. Thank you. That's the end of our presentation.
Thanks, Maggie. So Liz will be doing our last presentation, which will be done by Ruth. So I'll not introduce her again, as we had already mentioned what she does and her interest. So Ruth, we encourage you to go faster so that we give the participants opportunity to ask questions and also other presenters to do their presentation. So Ruth. Ruth, go ahead. I think you're muted.
Sorry. So I was saying that the presentation I'm going to do relates to a program called Kidogo Early Years, and it was effected during the COVID-19, when COVID hit the country. That was in the year 2020. So because of the pandemic, Kidogo initiated a response. And so this presentation is going to focus on that and some of the lessons that we've learned and the impacts or effects of that intervention in 9 urban informal settlements. So my presentation will take the format outlined. I've already alluded to the background. I'll speak to the objectives, the study design, the outcomes that came out of the caregivers or parents of children who are attending daycare, and also of the daycare providers, who in this case are called mamapreneurs, and then the effect of the intervention, and then I will conclude. So as I have said, the program was run during in 2020 for about 4 months when the pandemic hit the country. And the reason for this is because, first of all, COVID really hit the globe. It was a global pandemic which really hit the economies of different countries. And now in urban informal settlements, because this study is conducted in the context of urban informal settlements, the impacts were severe, because a lot of these parents or caregivers depend on casual work. And as I had mentioned before, a lot of these parents take their children to daycare centers to be able to get an opportunity to go look for work. Now, other than the economy, the childcare economy, or that economy of daycare centers, was also adversely affected. And it was affected because there was closure of schools And there was also the fear of infection. So there was an alternative at home. You'd find that parents had older siblings who they could leave their children with at home, or there was just someone who could take care of the child because people had also lost work. So the childcare economy of these daycare facilities also were hit hard with the pandemic. Now, as much as there were opportunities or alternatives, there are still gaps in provision of quality care, because in facilities that the care is sort of informed by an intervention or a program, then there are some minimums that, for instance, Kidogo has in terms of the kind of quality the children are getting. And also these parents, because they depend on casual work, needed an opportunity or needed a platform where they could leave their children. And so that gap emerged due to the fact that parents needed to participate in work and also the quality of care. And so Kidogo came up with a three-pronged approach in addressing the COVID pandemic. And the first one targeted children, where they provided play packs, which included learning and play materials. The second one was a WhatsApp platform where caregivers could get tips. They could ask questions and get answers on caregiving. And then lastly, they also provided a conditional cash transfer to mamapreneurs or daycare owners, where they had to provide, they're the ones who used to distribute the play packs to families. And so they got a cash transfer, which they could use to pay rent so that they could keep their daycare facilities open. They also got hand washing stations and some porridge flour to be able to continue running their daycares at even during the pandemic. So our aim as APHRC, we wanted to look at the feasibility and the effect of that model that was launched by Kidogo on the provision of care during the COVID-19 pandemic, and to see how some of those insights can be used to inform the new normal that we are currently operating in. And so how we set out to do the study, we had a pre and post intervention. The study was carried out this year, and so it was largely based on the parents remembering, or it was a retrospective study, which depended on their ability to remember what happened before Kidogo started giving the intervention, but the pandemic had hit, and after the parents and mamapreneurs got the intervention, that is after the 4 months. So we had about 231 caregivers in the pre-intervention and 87 daycare providers or mamapreneurs. So for the mamapreneurs, we were able to interview them at the pre and post phases, but for the caregivers, we lost a number of them. So for these categories of the two categories of respondents, we used knowledge, attitudes, and practice questionnaire. We also looked at caregiver-child interactions, and we also looked at parental stress, how they were. And we asked the mamapreneurs, based on the conditional cash transfer, different things that it enabled them to do as it relates to running the daycare facilities. So for the mamapreneurs, the questions, we had about 8 questions, but I'm projecting 4, which all turned to be positive. So what this means is that pre-intervention and at the post-intervention period, there was a change, there was a significant effect of the Kidogo intervention. That is the cash transfer they got, and also the other support that they received from Kidogo, the hand washing and the porridge flour. But the most significant support, as reported by them, was the cash transfer. So you can see on my extreme left, the mamapreneurs reported that they were able to run the daycare even during the pandemic. However bad the situation was, that minimum transfer or that cash amount they got from Kidogo enabled them to be able to run the daycare. So if you can see where I'm placing my cursor, you see at pre-intervention, it's at 53 women. It's at 46 women, or 53%. And at post-intervention, it's at 100%. And if you look across the if you look at down or along this scale of post-intervention, we see reports very high percentages compared to the pre. So the percentages are the ones in the brackets. So we see the percentages change very significantly. So we see that they were able to continue running the daycare. They're able to meet financial gaps resulting from emerging from the COVID-19 pandemic. And they're also able to have smooth continuity of childcare business, all at very high percentages, 99, 95, 99, and 100%. So we see a significant effect across all the variables that we asked them. They strongly agreed that the intervention was very useful for them to continue providing daycare services. So when we come now to the caregiver outcomes, we had a number of skills or issues we wanted to find out from the caregivers. And the first one was to check whether the intervention through the WhatsApp platform, where parents could get information or tips, or could ask questions about what they should do, or were enabled to do at-home learning, because a lot of the parents now had to step in and be the teacher. They got some tips and the learning materials and material making. So we asked them about questions about at-home learning, and that is largely related to their competence as parents to deliver at-home learning. So like the first variable you see, it's caregivers received information that improved playful interactions between them and their child. So we see that there's a significant increase, because at the beginning we had about 58.4%, but at post-intervention, which was a period of 4 months, we have 92.7%. And so if you look at along the margins of strongly agree, what is shaded in green, you find that pre-intervention or before Kidogo gave the intervention through the mamapreneurs, they all were below 60%. But post-intervention, we see that that all of them are all above 90%. So showing that the parents felt that the intervention was very useful and there was a significant change or increase in their competence as parents. So they report that the information they received was useful, and that they were able to do at-home learning, and they're able to develop the ability to continue providing learning opportunities to their children. Now, when we look for the caregivers, as I had mentioned, there was the competence, and that means the skills imparted to them by Kidogo, or the reports that they were able to receive information to enable them to carry out the issues that are pointed on this scale to continue with that home learning or improve their knowledge. Now, when it came to attitudes and practices, the parents did not report a significant change but because of resulting from the intervention. And some of the issues that there was no significant change is like the caregiver-child interaction. So when it comes to the caregiver-child interaction, we looked at 5 skills. We looked at this motor, that is how the children are able to move, their social capabilities, their emotional, their language skills, and their cognitive skills. Now, we did not see any significant change on the child and caregiver interactions in terms of the practices or any new things that were happening. So that shows a gap between the competence that was reported at a very high, that was reported to be significant, and the knowledge and attitudes. And this also was apparent that the parents already were doing some of these things even before the intervention. So some of the reasons that could explain this lack of significant change of the parents' interaction with the children is that the intervention was measuring them at a point where they already had some knowledge or had already had a mindset change. And so very little could be done by the intervention to improve their outcomes for the parents. Then in terms of the parental stress index, we also saw that there was really no significant change. Again, the community, there was a high level of awareness of issues that stress the parents and a separation from their childcare issues. The other thing that was apparent is that the intervention was delivered purely through the mamapreneurs. And so because all these mamapreneurs are individual business owners and have their own styles of delivery, then it could be that each individual determined how to deliver the intervention. And so no uniform pattern could be seen as an effect or an outcome of the intervention. For the mamapreneurs, as earlier indicated, the effects were significant all through for all the 8 items, mostly because for them it was the cash transfer that they reported a lot of benefits and continuity of the childcare activities that they received from Kidogo. So as I have mentioned before, that there was significant, this study showed that there was significant value for mamapreneurs. This is revealed by the pre and post intervention. However, for the parents, as I had earlier indicated, there was no significant effect on their knowledge and practices and parenting stress. And then also across the 5 domains, that is language, cognitive, and motor, and the others that I have talked about, there was no much change in the outcome because there were ceiling effects, meaning that they already had a lot of knowledge or were practicing a lot of these things that Kidogo was talking about even before the intervention came to play. So in conclusion, I would really like to recognize the funder, Echidna Giving, who was very gracious, who are very gracious throughout our study period. The study participants who are very gracious also to use retrospective methods to provide us with data during our pre and post, the Kidogo leadership and program team, and the research team that is outlined or shown there. Thank you very much. Over to you, Ken.
Thanks, Ruth, for that wonderful presentation. So we'll go to question and answer session, and I'll hand over this session to Lindsay. Lindsay, are you still with us?
Yes, I'm still here.
Okay, thank you.
So thank you very much, APHRC, for the presentations on the urban, informal, and diverse cultural settings. So I want to welcome at least 2 questions before we proceed to the next session because of time. Anyone with a question? As others think about the question, I think Rose has a question that she has put on the chat, and she says that experimental designs are handy in understanding ECD outcomes, but she has an issue concerning using control groups, especially if they have nothing to get in the research. How does this sound with regards to ethics of beneficiaries? And how did the researchers ensure that the control group is basically the research just for data collection? Maybe one of the presenters or any can respond to that as we wait for anyone else who has a question.
Could respond to that?
A quick one, Lindsay. I don't have questions. I just have comments.
Yes.
Thank you, the team that I just presented. Very elaborate research work done, very informative. I just wanted to say a few things on
Sorry, we can't get you clearly.
the issue that there were the initial presentation about informal care, informal settlements where people open caregiving centers, and there's no framework or a logical way of identifying who is a caregiver and whether they're registered, whether the government is involved, etc. I'm just saying that this is something, an area of concern. We need to look at it because this is how children get abused, and this is how children get kidnapped, or we end up with the cases of child trafficking. So something around that. And then you mentioned something about young parents, and in the informal settlements, just thinking there's need for more psychosocial support for parents or such groups, and livelihood interventions to ensure that they're able to cope, because probably some get pregnant and start parenting when they have nothing they can rely on to make sure they're able to take care of the young ones. And then you mentioned something around alternative discipline You mentioned about discipline being still a lot of traditional, caning and all that. Yeah, just food for thought. Probably we need to mull around what are the things that we can develop and share with the groups and beneficiaries and networks we have about alternative disciplinary measures, such as making sure children adhere to authority, whether they're being grounded or whether they're being kept behind to do their homework, or whether there's something that, or denial of privileges that ordinarily, not like for food, etc., but just being told you will not get your regular playtime, or you'll not get your regular candy or whatever, because you're not behaving well. But I appreciate your presentation. I've paid keen interest, and you guys have done a good job of it. Thank you.
Thank you very much, Raphael. Any of the others want to respond to the same to the issue raised by Rose?
Yeah, the reason why we do experimental, or what are they called? Not trials really, we have comparison groups, is a lot of the time the concept is just being tried out and not confirmed to have impact. So ethically, that's okay. And in the control or comparison groups, we try to see that the standard of care, whatever they are receiving, is actually going on. So in the control arm, the CHVs continued to monitor child growth, immunization, whatever else that they were doing before the intervention came in. They continued that, and the monthly meetings were also, calling them in. And of course, that was the routine going on before the intervention. They have monthly reports with HR to track on what they've been doing and any issues with children's health and growth, nutrition, etc. Without, of course, receiving the intervention. Ideally, of course, if the intervention had been tried before and it showed some indication of impact, then probably we could have used the delayed design where you still put them in the control arm, but at the end of the intervention period, the study period, you then roll out the intervention to even those that received nothing or the standard, care. But these are concepts that are still at early, formative stage or even testing stage that we don't really have evidence that they work. So we're not denying anyone anything that we know ethically that would be okay.
I wanted to add something, Lindsay, to what Maggie has said.
Sure.
Yeah, I think the question that Rose is asking is very valid, and it's a question that I think ethics committees are now asking. People go collect data on some of these settlements that we're talking about, and even in rural areas, we provide intervention to some group, and some group are not given anything, and then after we've collected the data, people just go like that. I think this is something that also came up in one of our studies in CIR. And what happened was that there was enough funds from the partner. So we collected data in a given period, and then when we are done, the fund or the partner decided to roll out the intervention even to areas that were deemed controlled. So sometimes I think that one of the things that could be done, especially if people are looking for grants for research, they should also look at an opportunity to address the control people after the intervention or after the data collection is over, because I think data collection is for a given period. Of course, there are some interventions that are actually age specific. So if the children are past that particular age, even if you give them that intervention, may not be very, very useful. But I think these are some of the things that we could also include even in protocol papers and put them as issues that we are thinking about. But I will say that in most cases, these are issues that are now new and they're coming up, and the discussions that are going on how they can be done. And in some instances, people have been given placebo, something that is almost looking like that one, whatever intervention that is being given, but that is in drugs or in other experimental field. But in early child development here, it's a bit tricky because some of these interventions that we give are quite age specific. And I think maybe that they have not emphasized, the ethics committees have not emphasized so much that this must happen. If you have an intervention, or if you have this, then this must happen, and then later you have to provide this intervention.
Okay, okay. So the moderator, I just wanted to say that really I appreciate what Silas talks about. Today, there's a lot of huge debate about using experimental designs with human beings. I agree totally with what he talked about in terms of opening up some kind of fund to really come back to benefit the otherwise used and dumped kind of population, so that they also have a reason to be in the research. But if you look at it in terms of what we talk about sustainability, even if it's a pilot project like what Margaret and Ruth were talking about, there's the issue of these parents already understanding that these practices are good because you go there and encourage them to continue. These are such practices that may live with this parent for a long time. So even if it doesn't have an effect today, it will have an effect in the future. And such parents really tend to maintain such kind of tempo. So that is why we are seeing it's just very prudent that we come back to the control group and also give them some little dose, however small, so that we see that principle of beneficence is taken care of. But we can't say it's only a pilot, because pilots usually are there for something crossing in our mind for scaling and going deep and going wide and remaining with the community once the project ends. So I think there are some aspects that remain with these parents, and the other ones that were controlled remain at their own stage without really being helped. So maybe we need to critically think about this, because it's really a big agenda in terms of experimental designs with human beings. Thank you. Back to you.
Thank you. Thank you very much, Rose, and everyone was responding on the same. So I think if we have any other questions, we might be able to put in the chat in the interest of time. We can go to the next session, and I think this should be brief because the next session has two presenters, unless Dr. Anil and Christine are present. But Janet is set to join us, and she'll also be presenting. So if you'll allow me, we can go to the next session, which will be brief, and we will be finishing. If Janet will not be available, we will finish in the next half an hour. So kindly bear with us. So for the next presentation, kindly allow me to do the presentation as it still under the nurturing care framework, and I will be doing my presentation and sharing my screen shortly. And as I share the screen, kindly put, if you have any additional comments, kindly put it in the comment section, then we can address that.
Okay, Margaret and Ruth, I would like to have your contacts, please.
So can you see my screen?
Not yet. Not yet, not yet. And Margaret and Ruth, please, I would like to have your contacts so that we can interact later.
Okay.
Yeah, please.
Thank you. Sorry. So I'm just trying to share my screen. Can you let me know if you see my screen?
Not yet, Lindsay.
So as we wait for my screen to share, I'm going to take us through my presentation. And my presentation is a bit, is not focusing on the urban and the informal settlements that, like we've seen in the previous presentations, but my focus is going to be on the rural areas of Kenya, particularly in Nakuru County. So my name is Lindsay Nyamboki. Work as a project officer for the ECD project at Build Africa Kenya. Build Africa Kenya is an affiliate to Street Child International UK, which is a registered NGO in Kenya. Basically, we implement education and livelihood projects. And what we envision is to ensure that every child is in school, every child is learning, and every child leaves school with a desired skill for the successful future. So we are centering around the skills that children get while they are in school to ensure that they get quality education. We are currently operating in Nakuru and Turkana counties, with the potential to go into Narok County next year and possibly in Laikipia. And what we do is that we empower communities to support children to overcome barriers to education. And we work with the poor and marginalized communities in partnership with other development actors to identify, address challenges that communities face in accessing quality education and sustainable livelihoods. You can see my screen now.
Not yet.
No, we can't see. Yes, it started sharing.
So kindly allow me to proceed as I think it's still loading, but I'm projecting my screen.
Maybe you stop and then you start again. You stop presenting and then you start up.
Okay, my screen seemed to have hung, but I'll just proceed in the interest of time.
Probably you can just continue the discussion. If it comes
Yeah.
up, well and good. But probably you might want to disconnect it again and then try reloading it back again.
Sure. So I'm looking at community participation in the implementation of ECD programs in Gilgil sub-county. So my presentation is looking at how the community is participating, or how we engage communities to participate in ensuring quality ECD education. So as we all know that the growth and development of children is mainly influenced by the family and the community, and the support which the parents get has the potential to positively contribute to their learning outcome and their different outcomes in life. However, the biggest stress to ECD affects caregivers who look after children, and this has an impact on the quality of care that children receive. So if that in the rural areas, if they have challenges, especially with their livelihood aspects, then that means that the quality of care might be lacking or might not be inclusive.
Lindsay, we lost you totally. We lost you, Lindsay.
Lindsay, we can't hear you. Can you change to a different line or I mean internet connectivity?
Yeah, we lost you.
If you have a different, we can't. We have totally lost you.
Lindsay, we lost you.
Let me try and call Lindsay on phone and see if she's aware she's not. Or
yeah, that's a good idea.
That would be great. Yeah.
Ruth, meanwhile, we can be talking. Hi, Ruth. Hi, Ruth.
Hello, hi, Rose.
Yes, I really wanted to know whether you have an office in Kisumu for the Kidogo program.
So no, Kidogo does not operate in Kisumu. I think my colleagues can correct me if I'm wrong. What I know is that while Kidogo is a program away from APHRC, we were only evaluating the program. However, we are working with them on a number of projects. So like in Nairobi, the presentation that I did on the COVID response initiative, they were working in about 9 informal settlements. So they started work in Kibera and Kangemi. Those were the initial areas of operation, as well as Githurai. So they had centers of excellence or hubs based in those 3 urban informal settlements. And they also partnered with women who are private owners of daycare facilities, where they sought to bring the quality of services to a higher level by training them and mentoring them continuously. So there's another project that has been launched in Nakuru, which is the other area of operation that I know that Kidogo is in, and maybe Ken can speak more about that.
All right.
Yeah.
So Ken,
for Kisumu, I'm not sure there's been any work there.
All right.
Or if there are plans to expand that way, but they've been expanding quite a bit in the last few years.
All right.
Yeah, and majorly targeting informal settlements, and yes, in urban areas like Kisumu. Well, Kisumu would be a good candidate, but I don't know if they are planning to expand in that direction.
Okay.
Yeah.
Good. So I would love to get some contacts again from Kidogo. So Ken, what do you have? Because Ruth also thinks that you can inject more ideas in what I'm asking.
Yes, so what Kidogo does, or what we have partnered with Kidogo to do in Nakuru, we are looking at improving quality childcare services at the daycare centers. And by doing that, we hope that women will use such services and then get enough time for to engage in productive labor force, and also get also improve at their work. So that is what Kidogo is working. What we're working with working with Kidogo in Nakuru County. So they are working with the daycare centers, in which they are improving their quality through mentorship, which Ruth has mentioned, as well as training to improve the quality of the services that daycare centers caregivers are offering, and then ultimately enrolling more caregivers. And many caregivers are now will be able to engage in productive labor outcome. Yes, I can see Janet has also said that she's there, and is using the link that no, she mentioned to me that she's joining, but I've seen she has also joined, and she has renamed. She need to rename her name there. It is written as Kenneth because she has joined the link that I shared with her. So maybe Lindsay, she can do the presentation as they are waiting for the other person to make a presentation.
Thank you, Ken. Thank you, Ruth. Thank you. Okay, Lindsay is away. So Ruth and Ken, thanks so much.
Hello. Yes, I'm on. Sorry about that. Can you hear me now?
Yes, yes, we can. So I was saying that what if Janet makes a presentation as you're waiting for the other presenter?
Okay, I was mid the presentation.
It is Lindsay who is back.
Yes, I'm back.
Yes, I think she should just go on then.
Okay.
Yes, sorry, I'm not sure where you lost me, but I was looking at some of the issues that are the challenges that that ECD is facing in Gilgil sub-county. So in terms of our approaches, we have different strategies or approaches that we are doing to ensure that there is support in the ECD centers. So one of the approaches is that one, we are improving access to health services through facilitating linkages with government health officials. And this is done to ensure that we address critical factors for child development in the community, including development, health, and nutrition, and the importance of play for children and child safety and security. Then secondly, we are doing capacity building sessions for community leaders and parents so as to support them to identify and address gaps that exist in the delivery of early learning, including male participation. So in the sessions, we encourage the males or the fathers to actively engage in the ECD matters in the community as well as in the schools. So the other aspect is that we are increasing skill capacity among the ECD stakeholders. So we are currently training the sub-county ECD coordinators, who are 11 in the 11 sub-counties in Gilgil, and also increasing the skills of ECD teachers to deliver holistic skills. And we are doing this through training on the manuals that we've produced under our project. So the manuals cover pertinent issues that affect issues of early childhood learning and development. And these include issues of responsive caregiving, health, nutrition and care, early childhood care and development, and human and economic growth for the children, and also issues of including children with disabilities in our projects or in our interventions. We are also promoting inclusion at the ECD centers for people with disabilities, whereby we are doing accessibility adjustments for the ECD centers, and also sensitizing the communities on how to include children with disabilities so that they can learn the basic skills at the ECD level. Then a key aspect of our intervention is improved capacity for parental support, because this is an important part, because the parents are the initial or the primary caregivers. So we train the parents on through the parental care centers, and these parental care centers are places where parents can be able to meet and discuss issues around parenting. So we improve their capacity through bi-monthly sessions on how to better take care of their children, both at home and in the school. And we also promote livelihood diversification through synergies that we have in our livelihood projects. Then lastly, we ensure parents have skills to attend to children who are not attending formal ECD, either due to insecurity or distance or even disability. So we are equipping the parents to be able to attend to children, both in the home setup and also in the school setup. So what are the impacts that we are foreseeing or we want to achieve in our interventions? We expect to see increased knowledge about vital issues connected with ECD. This includes issues of cognitive development, health and nutrition, importance of play, and issues of responsive caregiving and child safety and security for the parents as well as the community. We also are envisioning improvement in community ECD support, whereby ECD is going to be supported, prioritized, and stakeholders are going to participate in ensuring quality ECD services. Then through the parental care centers, we improve capacity for parental learning and general parenting and caregiving skills, so that parents are able to address issues and ensure that they give the children the care that they need. Then we have increased linkages. We want to see increased linkages of the ECD centers with government provision in health, nutrition, and sanitation, so that we can reduce on the aspects of malnutrition and stunted growth. In the ECD centers, we are foreseeing improved rates of access for preschool children to integrated ECD learning, and also increased capacity skills for ECD center teachers as a result of the training in our project. And lastly, improved inclusion at preschool level through the measures taken to institute disability access improvement and community sensitization. So as a conclusion, we've been able to see that targeted programming on caregivers and community and participation is key to providing an enabling environment, because once parents are supported through the community systems, then they can be able to give the necessary care for their children. And then in terms of ECD programming, you're focusing on the quality provision of learning environment is key. Engaging teachers and families with early care and education programs are also vital for improving the learning experiences of young children and the educational outcomes. And lastly, building the skills within the family, community, and the school is critical to ensure that each child has access to requisite ECD skills, whether they can access formal education or not. So thank you very much. Sorry about the connection. I was not able to share my screen, but I've been able to give a brief on my presentation. So I think is Janet available in this session?
Here, Janet was here.
Janet,
now she's not there anymore.
I am here. I haven't left.
Oh yeah. Wanted to get you.
Okay, so Janet.
Yes.
Kindly take us through the last presentation of the day. And you are presenting on inclusion and aspects of child protection, right?
Yes.
Yeah, Lindsay, if we could allow rights to other participants probably to share documents, because I think somebody was willing to share the document which you are presenting on, I think from their end, and I probably just didn't see the message.
Okay, I will look into that. I've just presented through my phone, but once my computer is up, I'll be able to share. Thank you. So okay. You can put the comments in the chat section as Janet prepares for her presentation. Janet, welcome.
Thank you, Lindsay, and the entire group. I think one of the biggest challenges we had, I might have been in one of the groups that was participating like parallel to you. That's why when we were locked out, the host removed us. So maybe that's why also the presentation cannot be projected. I've been trying to project my presentation, but it says that the host has to allow me to project my presentation. And therefore, I'll just go through my phone. Also, I was not able to connect through my laptop after I was removed from the first group. So my presentation is based on inclusion as an aspect of child protection. And this is a case study of a childcare center in a childcare center in Dandora, which is near the informal settlements of Korokocho, where I have had majority of you also do some presentation. And we have been looking at inclusion in the aspect of bringing children that learn differently into regular ECD centers, capacity building, both biological and professional caregivers on the know-how on how to bring, or sensitizing them on the importance of bringing children at the early years in the regular childcare centers. Therefore, according to UNESCO, less than 1 in 50 disabled children attend school. And this negatively affects their holistic development, denying them the opportunity to reach their full potential. And that's why the vision of Nyota is to see all children receive quality learning environment irrespective of where they come from. When I'm talking about the aspect of child protection, we know children with disabilities, majority of them face their first attempt of an abuse from people they trust, from families, and also from the church. And therefore, the goal or the vision of Nyota is to see these children who learn differently with the various disabilities, attending childcare center, coming to learn with the children with who are regular or average children, but not being discriminated. We have been able to use a model in comparison to the nurturing care framework that has the 5 elements, but Nyota has picked 3 of the elements that are more to the nurturing care framework. The play, which is the aspect of the opportunities to early learning, the child protection, which goes hand in hand with the safety and security of the child, and the inclusion as part of play being a right to the child. Every child has a right to learn. So our model for Nyota, we are using play to stimulate learning for these children who learn differently in a regular childcare setup. What has been our interventions? Our interventions have majorly been led by play, helping parents and both biological and professional caregivers to be able to use play in stimulating learning, and apart from doing the stimulation of learning, also helping children to be able to identify or prevent any form of an abuse in their early years. We have also been able to train the caregivers, to capacity build the caregivers through trainings. And through the monthly trainings, we have been able to form parent support groups, who are able to meet once every month and be able to share different case scenarios or different ideas on how they can assist each other in helping a child who has a disability. Apart from that, we have also been able to work with the children in their classroom setup, because we found out that even if we do the inclusion in the school environment, we also noticed that there was exclusion between the learners. And these are learners aged between 3 to 6 years. So we found there was entire need also to empower the children to accept and also include their peers in learning together, playing together, and working together. So this program has been ongoing for the last 1 year. And so far, we have had 2 childcare centers, one in Kibera and another one in Dandora. We have built the capacity of children. We have seen children now accepting to play with their own children and to be in the same setup with their colleagues who are learning differently or who have various disabilities. Apart from that, we also had the caregivers, teachers saying that in case you want to work with a child who has a disability, you have to be trained on that. And their attitude was different during the initial stages, but we have had the caregivers change their attitude into appreciating and also accepting these children and learning, helping them to learn different skills apart from the academics. The community. The first time we started this project, majority of the parents who had children who were average or regular children pulled out their children from the childcare centers because they felt their children could not learn in the same setup with the children who are learning disability. However, the ones who are able to remain behind, they have been able to change their attitude, and now they are the ones who are encouraging others to bring out their children from their homes and attend the child care centers at this particular time. Last but not least, majority of the administrators in this environment were not admitting children in the ECD centers until they reach the age of going to primary. So now we have had an opportunity where several administrators are now buying the idea of admitting children at the early age in their child care centers and helping them through collaboration, networking with different other organizations. Last and not least, we are happy to say that we look for us to make the future of these children to be holistic, we are looking forward to joining hands with people who are working in the same environment, and more so changing the perception from the society and letting them bring out these children at an early age, because we believe the early the identification, the early the intervention. And this is really giving a great gesture to the community within. So we are looking forward to empowering the societies or the communities that are living within the child care centers, and also empowering the teachers through taking them through capacity building sessions where they can be able to know how to deal with children with such learning disabilities. Thank you. That is what we had from Nyota.
Thank you. Thank you very much, Janet, for the presentation. So I'll allow the next 5 minutes for anyone who might be having any questions or comments before we close the session. The floor is open.
Hello. Hi,
Yes, Rose, I can hear you.
Yes, thank you so much, Nyota, Janet. Thank you for that. I just wanted to know from you, you have mentioned that you still work, you go and get an opportunity even to work with children in the class. How does this play in terms of the teachers? Okay, at what time do you get into sensitize the peers of children who are apparently supposed to be playing with the children with special needs? And how does it play in terms of the school context as you do this? And then on to Lizzie, I found out that your program is really having a lot of components, that you are dealing with. So maybe amongst all the components that are playing in the background with regard to this program in Nakuru, which one is coming out as a more prominent kind of intervention? Because I always know in Kenya, there are certain things that really play, they just come out automatically, especially when we are dealing with very highly vulnerable populations. In terms of livelihood, is it the one that is playing a very big effect in terms of that change of attitude and a response toward that intervention? And if that livelihood is the one that is it sustainable for us to be working with, giving goods, giving goodies such that when the project goes, you go with it doesn't remain in the society. So I'm just asking about which one is coming out, and if it is livelihood, then what next happens when you leave that site? Thanks.
Thank you, Rose. Anyone else with a question before we respond? You can take maybe 1 or 2 more before we respond. Well, I'll take the silence for no question. So maybe Janet, you can respond. Then I can respond to my question. Janet.
Lindsay, Rose, kindly, if you wouldn't mind, you may just ask your question once again. I think I didn't get the last bit of it. Kindly.
Quickly, I know time is not on our side. You have mentioned that you, for the sake of children, embracing those children with special needs, you get into the classroom. Yes. You follow them up, because the issue of embracing in the classroom has been a problem. Actually, it is a problem. The children can be in school, but not really playing with the others. The stigma is still there. So how does this play in the context of the school? Because the school has its own schedule, has its own routine. There is that kind of quick fix in the school being a very academic oriented component. How does it play even when you come back and be in class with the teachers? You know, the teachers usually have a territory to man. So how does it play? Is it very easy to move around the school and doing all these activities?
Okay, thanks, Rose. I think some of us have the benefit of being classroom teachers, and that one also gives us an opportunity, and also the flexibility of the administrator, and also the number of children, the population of the school. A class has around like 10 to a maximum of 15. And this has given us, that's why it has given us a better opportunity like to interact with the children more, and also give them like take homes. When you tell them like to draw some pictures and we assign them to do them with their parents. The parents, when they come for their sessions, they also share with us on how the children talk about the other colleagues in the classroom. And one of the biggest advantages we have done in the childcare center, we've just had a ratio of like 2:2 children with learning differently are put in a class that has like 10 children who are average. So the accommodation is easier, and working with the teacher also during those like 30 minutes or 40 minutes or 2 hours is far much flexible for us. So that one has really given us a better opportunity to work with such children.
Thank you, Janet. Hope Rose, the issue has been answered. On the question that you raised on our project, yes, we have many components which are interrelated, but the more prominent intervention are two. First and foremost, which is critical, is the parental skills. So
Lindsay, could you people speak a little closer to your gadget so that we can hear you?
Sorry. Yes, I'm saying one of the prominent features of our project is the parental, building the skills of the parents within the family to ensure that each child has access to the requisite ECD skills. So basically, that has been prominent because once parents are aware of their roles, they support ECD, and as a community, they're better able to support the children under their care. And then in terms of our livelihood projects, we take the parents through a livelihood diversification, where we empower them or we build on what they're already doing. So it's not more of handout, but more of capacity building them to be able to support their families and also to support their children's education. Thank you. So any last comment or issue before we close? Anyone with a burning issue before we close the meeting? Well, if there are no comments or issues, then for me, I would really want to thank you very much for being patient to be able to attend this session from the beginning up to the very end. Thank you very much for listening in and participating. And apologies for the mix-up, especially in terms of network and also coordinating with the people on the ground. But I want to say that we've been able to learn and share from the different presenters that have been able to present here. So with that,
yeah, Lindsay, a quick one. Thank you very much for coordinating these sessions. Please just take it up with the ECD Network and Total News regarding the confusion around the kind of sessions we were meant to be attending, because it's only meaningful if things are coordinated in a very structured manner that allows people to spend their time meaningfully. I think we spent a lot of time just trying to figure out where we were supposed to be. And yet these are links that was sent earlier on. And then there was another session going on differently, which we were not aware of. So please do raise this with the organizers.
Thank you very much.
Also, Lindsay, maybe just a request for those of you who have, I'm really interested in your PowerPoints. I don't know whether you can be able to share with me. I've shared my email. So maybe if you can have it somewhere in your notebook and help me just get those PowerPoints, I will so appreciate, please.
Okay, thank you. Kindly share your email address again. I'll be able to share my PowerPoint. And thanks, Raphael. Your concern is noted, and we will report the same to the ECD network.
I have my email there, and I will be welcoming you soon to Kakamega. We're also running another program, which I'm really finding a lot of information about what goes around what you people do. So my email is there. Thank you so much, Lindsay.
Thank you very much, Rose. We'll be able to communicate further. I want to thank everyone once again for participating and for being patient to complete this session. So I will want to call this meeting to a close. I wish you a good evening and see you tomorrow, hopefully. Thank you very much. Before we close, can someone close for us with a word of prayer, kindly?
I can pray. I will pray.
Okay, Rose.
Okay, thank you, Lord, for giving us this opportunity even to be here, Lord. We thank you because we had asked you in the morning that you be with us, Father. You have been our silent visitor and a silent listener to all the conversations that are making the Kenyan child today and tomorrow. We thank you even for the kind of sessions that we anticipate tomorrow. We ask you that, Lord, we are going to go back to our homes. Protection is going to be guaranteed because of your mighty name. And whatever other activities we are going to involve ourselves in the night, Father, we want to put them into your hands because you know we care. We know you care for us. Thank you, Father. Keep us together until we meet tomorrow. In Jesus' name, I want to pray and believe.
Amen.
Amen.
Thank you very much, everyone. Have a good evening.